Hi, everybody. Welcome to the last lecture of BL 620, Biomedical Microbiology. And today, for our last one, we're going to talk about a couple of different fungal pathogens. We don't talk about them a lot because they're pretty rare, except in immunocompromised patients or the ones that you learned about in your first TBL. So today, we're just going to cover two, Aspergillus and Candida. And you've all heard about Candida before, I'm pretty sure. When I was trying to find a quote for today's, I couldn't find a very good one that had anything to do with actual medical fungal infections, but I thought this one was pretty funny. All fungi are edible. Some are only edible once. Has absolutely nothing to do with what we're talking about today, but I included it for a few laughs at the end of a crazy semester. Okay, so Aspergillus and Candida. Let's go ahead and get started. Okay, medical mycology is the particular field of medicine concerned with diagnosis, management, and prevention of fungal diseases. And we call fungal diseases mycoses. All right, so when you hear mycology, that's the study of fungi. That may be a new word to some of you, and infections with fungi are called mycoses. Okay. Fungi can have a few different shapes. There are yeast, which are round ovoid cells. Remember, they're eukaryotic, so they're much, much bigger than bacterial cells. Or they can have these branches called the hyphae, like this, that can be septate, meaning they have like clear divisions between them, or non-septate. And these morphologies can be important for diagnosing fungal infections and determining like what type of fungus your patient has. They can be difficult, though, to diagnose and to treat for a number of reasons. Often, the signs of mycoses can be missed or misinterpreted. So if you think about some of the fungal mycoses we've learned about before, like histoplasmosis, that could be misinterpreted as pneumonia or as asthma. So they can be missed or misinterpreted depending on your patient's situation. And they can be hard to treat because many fungi are resistant to antifungal agents. So while some respond really easily to antifungal drugs, others have resistance, just like we see with bacteria and viruses, so treating them can be trickier. So we can divide mycoses into two main categories. There's what we have called the systemic fungal pathogens, or the true pathogens. So these are the ones that are going to cause disease. They're not a part of our normal microbiota. These generally have the ability to actively attack and invade tissues if they're going to cause disease at all. They generally exhibit dimorphism, where they have differences in shape depending on the temperature or the pH that they're at. So this should sound familiar to you, where in the environment we have one shape of our fungus, like these with hyphae that are branching. And then at another temperature, like in the human, they convert to a budding yeast type form. So depending on how we grow them, we can see two different shapes. And then there's some nice pictures down here where you can see the hyphae with their spores coming off the ends. And over here we have our round or ovoid yeast cells. And again, these are true pathogens. They're not part of the normal microbiota. Now, we have talked about these before. You may remember we, in your TBL packet, you covered coccidioides, which is found here in more of the southwest region of the United States and some parts of South America. We also talked about histoplasma, which is kind of in the Ohio River Valley region and the eastern part of the United States. These are endemic to certain areas, right? So usually it's just in the Americas, but our histoplasma can also be found in Africa. So if you recall our case studies that we did on these for TBL, some of them had a link to the region where a person lived. and others had a link where maybe a person had lived in one region and moved to another. So we've already talked about a couple of true fungal pathogens in the past. But the ones we're going to talk about today are opportunistic fungal pathogens. So aside from a few true pathogens, the rest of the fungal agents are opportunistic. So they are either commensals or they're natural, environmentally occurring fungi that can take advantage of a weakness in a host's defenses. Again, they're often normal microbiota, Candida being the big one that's a microbiota here. And I want you guys to pause for a minute and think to yourself, what are the conditions upon which an opportunistic infection can occur? So remember, what are those changes in a human that allows for opportunistic infections to set up and take place? Okay, our opportunistic fungi, or today's focus. We can break them up into 4 categories based on the level of penetration of the infection into the body's tissue. So do they stay on the skin surface? Do they stay in the mucous membranes? Or do they invade further into the host? So if we look at them from deepest to most superficial, we have our systemic or our deep mycoses, as they can be called. These are the ones that can infect internal organs and can spread throughout the body. Next up is what we call our subcutaneous infections. So these are the ones that can be below the skin. They can involve connective tissue. They can infect bone tissue. Then we have our cutaneous. So these are the ones that you often think of when you think of fungal infections. So the outer layer of skin in nails. So you think of people, if you've ever seen someone with a fungal nail infection, that nail gets really, really thick. Or in hair shafts, and that a bad fungal infection in hair shafts causes dandruff. That's actually belongs to the genus, I think it's Mycoses. We're not talking about that one today though. And then there's what we call the superficial mycoses. These also get called the dermatophytoses, and you've heard them called ringworm, right? Ringworm is not actually a worm, it's a fungal infection, so called because it is round like a ring. So these superficial infections are generally caused by fungi that can grow on the outer dead layers of the skin and hair, on the nails. And what we can see is that an opportunistic infection with a fungus can begin as something superficial and can maybe invade a little bit deeper depending on the fungus itself. All right, so 2 different fungi that we're talking about today. The first is Aspergillus. And then the second is going to be Candida. So Aspergillus, this is a lovely EM of its conidium and all of the little spores that are going to be released into the air. A little diagram of it. And then down here, I wanted to show you a better picture of these branching septate hyphae. Because doing a stain from biopsy of Aspergillus, one thing that you would look for is branching septate hyphae. So these lines here, I'm going to run this laser pointer next to it, are the hyphae. And you can see, right, going across right here, those are the septa. So this is a septate hyphae because we can see clear divisions between different cells along that hyphae. They are branching. I mean, that's obvious. It looks like a tree branch, right? So we have this one hyphae that then branches off, and now we have 2 hyphae, and there's a branch point right here. And if we look at this one, there's a couple of branch points along that way as well. So branching septate hyphae. So Aspergillus, the diseases it causes are called Aspergillosis. And there are several diseases caused by various fungi in the genus Aspergillus, and we're just going to talk about the genus at large. We're not going to talk about different species of Aspergillus. So unlike histoplasma or coccidioidy mycoses, Aspergillus is ubiquitous in nature, so we can find it in soil, in water, in different temperatures, high and low. And it's pretty much distributed worldwide. So we don't tend to see a regional association of Aspergillus infections. Diseases caused by Aspergillus occur when a person inhales the fungal spores. Okay, so similar to what we learned about before. You can inhale these fungal spores and it begins an infection in your lung. These spores are pretty heat resistant. So we can have infections that occur in very hot, dry areas of the world, as well as those that are more humid. Also, because of the hardy nature of these spores, we can see nosocomial infections with Aspergillus. So ones that occur in the operating room. So maybe some spores fall into a surgical incision, or our patient is inhaling them. And there can be outbreaks in hospitals. One of the reasons is because this fungus can grow in air vents, where it can tend to be a little moist because of the humidity in the air. So many operating rooms and hospitals have specialized air filters that will filter out those fungal spores so that you don't have outbreaks of Aspergillus and other airborne diseases there in the hospital, because that's bad. So there are 3 pulmonary diseases that are most often caused by Aspergillus. There's what's called hypersensitivity aspergillosis. It can also be called allergic aspergillosis. So this can either manifest as asthma or as other allergic symptoms, or it can exacerbate asthma in a patient who has asthma already. There's non-invasive aspergillomas and non-pulmonary aspergillosis. So first, we're going to talk about our allergic aspergillosis. In this case, a patient inhales those spores of Aspergillus. It can get, because it's so tiny, it can get all the way down into alveoli of the lungs. But in this case, it's not incredibly severe. It's usually pretty transient. So we'll see pulmonary infiltrates if you looked at a chest x-ray, but they may come and go. The fungus tends to set up sort of pockets of replication in areas of the lungs that may have poor drainage. So if you have a patient who already has some fluid buildup in the lungs, you're more likely to see Aspergillus sort of accumulate in those areas that are not getting drained. And a hallmark of this type of aspergillosis is that your patient should be experiencing eosinophilia. Right? We don't see high eosinophil counts very often in our infectious diseases, unless it's a eukaryotic pathogen that's infecting our person. So we'll see eosinophilia with allergic aspergillosis. The second one I'm going to tell you a little bit about is invasive aspergillosis. So this one is often associated with or after a round of tuberculosis, or in patients who are otherwise immunosuppressed. So what happens here, rather than this transient coming and going of infiltrates, these spores make it into the lungs and they begin developing hyphae. And these hyphae start to penetrate into the tissue. Remember, the hyphae are the branch-like parts. So these branch-like parts start to invade into the tissues of the lungs. And what they can actually do is form aspergillomas, right? So think about granulomas in tuberculosis. They're these round masses that the arrows are pointing to here. Okay, so they're like little balls of fungus inside our patient's lungs. Okay, so they look kind of like those masses, the granulomas that we see in tuberculosis, only in this case they're fungi instead of that highly structured granuloma. Now, usually it just stays here in the lungs. If our person is severely immunosuppressed, it can migrate from these masses, get into the bloodstream and circulate throughout the body. It can be seen in places like on the skin. So you can see this sort of inflammation around the eye of this person here. But occurrences of aspergillosis outside of the lung are pretty rare. And again, we really only see that in immunosuppressed patients. We don't see it in a lot of other people. Diagnosis, treatment, prevention. Fungal infections, in general, it's pretty easy to diagnose that someone has a fungal infection. It can be more challenging to diagnose what type of fungal infection they have. Aspergillosis, you can take a sample and you can throw it on some specialized agar that allows for the growth of fungus, and it grows really quickly. But that's not the best way to diagnose it, because aspergillosis is a really common contaminant in labs. Aspergillus is a common contaminant in labs. So often, if you've ever worked in a microbiology lab and your plates start growing stuff, that can be Aspergilla because it is found in the air. So to really diagnose it, to say for sure this is what it is, you'll need an aspirate from the lung, perhaps a lung biopsy, or fluid from a bronchoalveolar lavage. So you have to do some sort of invasive type of testing to completely diagnose the disease in the lungs. Now, once you've taken an aspirate or a biopsy or a BAL, you can slap some of that on a microscope and you can look for those branching septate hyphae, and you can even look for the formation of those like the candidiaspores. After you see it microscopically, you can then go on to confirm it with culture and make sure that's what you have. In allergic aspergillus, you can use serology, so you can look for antibodies to aspergillus. It's not as useful in those invasive cases because many people in just the regular population already have anti-aspergillus immunoglobulins because we've come in contact with it before and not gotten sick from it. So it can be handy to sort of help confirm a diagnosis or an allergy when we're looking for specific types of antibodies and specific types of responses, but not so much in the invasive aspergillosis. You can treat Aspergillus infections. There are a number of antifungal drugs that can work pretty well, particularly if your patient has non-invasive or allergic aspergillus. So you can treat it, clear it up. In the more invasive types of aspergillus, treatment is a bit harder. So remember these fungal balls that we have here? It's very hard for drugs to penetrate into the middle to kill off all of the fungus in that ball. So treatment of our invasive forms is not as useful, and the mortality rate of invasive disease is fairly high. So treatment is warranted, but it's not 100% curative in invasive disease. And prevention for this one can be kind of tricky, right? Any pathogen that is ubiquitous, that's in air, that's in water, that's in soil, it's hard to prevent for those without an effective vaccine. So the best way to prevent for things like aspergillus is air filtration devices that you would see in hospitals to prevent outbreaks among people who are already in a compromised state. Okay, so that's aspergillus. Next up, we have Candida albicans. Excuse me. You guys have heard of Candida. I know I've mentioned it before. It's one of those common opportunistic infections that people get after having a round of antibiotic treatment. So often when women experience a yeast infection post-antibiotic treatment, that's the outgrowth of Candida albicans. And it's able to grow out because the normal microbiota, the normal bacterial microbiota, helps to keep the growth of Candida in check. And when antibiotics kill off that normal microbiota, now Candida can grow without restriction. So Candida most often is found as oval yeast cells. And so this picture up here in the corner, in the top right corner, shows us kind of all the different forms that Candida albicans can take. So these round ones that we see up here is big, massive, round yeast-like cells. And it can also form hyphae, so it is dimorphic. It forms hyphae upon changes in things like pH, temperature, and we see that this change from purely yeast-like cells to now hyphae-producing cells does happen during infection. I'm not going to go into the detail of the virulence factors and changes there, but it's important to know that it does happen. So you can see the hyphae coming out through here, all of these long strands that you can see coming away from our yeast-like cells, or our hyphae. So one of the tests that can be done for diagnosis of Candida is what's called a germ tube test. What that means is growing the yeast, the fungus that's been cultured from somewhere, and looking for the beginnings of these hyphae forming out of a yeast cell. So this inlaid picture here, the round things you can see, these are the yeast-like cells, and these sort of tubes coming off of them, these germ tubes, are the beginnings of the hyphae forming. So if you have taken a sample that you think might be Candida, you grow it on agar for a while, and you look for the formation of these germ tubes. If it's germ tube positive, then it's Candida. And we'll come back to that when we talk about diagnosis. So there's a lot of different Candida species, about 150 or so of them. About 10 are associated with human diseases. The one that's the most associated is Candida albicans, and it is the normal microbiota of pretty much all of our mucosal membranes. So we have it in the oropharyngeal mucosal membranes, see it in the mouth, in the gastrointestinal tract, and in the female genital tract. So it's very common to have on your body, which makes it the ideal opportunistic pathogen. It's already there, it's ready to take over when conditions are favorable. So diseases caused by Candida albicans are referred to as candidiasis. Again, opportunistic infection. We can see it when the conditions are just right. So if there's sort of a change in the body, if a person has taken a strong or long dose of antibiotics. And what happens is those yeast initially start by attaching to extracellular matrix proteins. So they attach to the cells of the mucosal membrane. And then under altered conditions, these hyphae start to grow. So if we kind of look at these top two pictures here we have our yeast cell, and the hyphae is starting to grow. And this may be due to changes in pH and the normal balance of the microbiota. And then these hyphae continue to grow and penetrate down through cell layers and deeper into tissues. So eventually, if these penetrate far enough, they could reach a blood vessel and could become more disseminated through the body. We don't see really severe candida infections that get into the blood vessel and cause systemic reactions that often, but there is the potential that it can happen. And Candida, like all pathogens, is able to evade the immune system. One way it can do it is through degradation of C3b, either via accumulation of factor H or through some of its own proteases that it makes and can cleave C3b. It also has some ways to prevent recognition by toll-like receptors. This is important if you're going to be part of a normal microbiota, but also aids in disease. And if you guys have really learned much at all about fungal infections prior to this, you know that they cause a really wide range of diseases. So those of you that have kids or have had any babysitting experience, diaper rash. Diaper rash is caused generally by Candida albicans. So this is a really severe case of it. Again, it's still opportunistic. It grows really well in moist, dark areas. So areas under a diaper that are not keeping a baby particularly clean can have an outgrowth of Candida. Also in really pudgy babies, you can have yeast infections in the folds of their skin where it's hard to clean them out really often because of their cute little baby fat rolls. Another really common infection with Candida is thrush. So in little figure A here, you see the white on this child's tongue and lips. That's the outgrowth of Candida. So in breastfeeding mothers, what can happen is that the Candida, which normally lives in the mouth, can be passed to the skin of the breast, and babies and mothers can sort of pass candidiasis back and forth for the duration of breastfeeding. So you have to treat both mother and infant in that case. Again, nail bed infections, there's also eye infections and vaginal yeast infections. So that's just a smattering of diseases that Candida can cause. The next two slides are a big table of different diseases that Candida can cause. Like I always tell you guys, don't try to memorize this whole table. You don't need to know it all. A lot of these are really rare and don't happen very often. But I'm just going to highlight the ones that I've already mentioned. So thrush, the white plaques on the mouth, on the tongue. We see it in babies, like I mentioned, but we can also see it in people with uncontrolled diabetes, AIDS patients, cancer patients. When my dad was undergoing cancer treatment, he had thrush. He said it was terrible because he couldn't taste anything from his food. And so we see it often there, right, because there's immunosuppression. Cutaneous types of candidiasis, so like diaper rash. Again, the moisture, the warmth there in the diaper area and skin folds allows for growth of the fungus. Vulvovaginal, so usually this is due to the use of broad spectrum antibiotics, changes in the microbiota. This one is characterized by a very creamy, thick vaginal discharge, often also burning sensation in the vagina or in the vulva as well. And then in our second slide, ocular. So I showed you a picture 2 slides ago now of a Candida eye infection. So if you kind of flip back to that after listening here, what you'll notice is within the eye, there's a sort of whitish lesion on the bottom. So people will report cloudy vision. It seems like there's a veil or something over their eye where they can't see that well. Usually this is due to disseminated candidiasis. I'm having trouble with that word today. Disseminated candidiasis. So in a patient who is immunocompromised and it has gone into the bloodstream and spread to other parts of the body. IV drug abuse can also be seen, or some sort of physical trauma to the eye, like scratches that have allowed the fungus to sort of bypass the normal eye defenses and set up an infection there. So this happens, but it's still pretty rare. And as you can see, there's this whole other set, like hepatic and splenic candidiasis. But again, these are in really more severe predisposing factors that we see the more rare types of candidiasis. I'm going to say it correctly before this lecture is over. Candidiasis. Okay, we can diagnose this disease. I'm laughing at myself and my inability to say the name of this disease. Okay, we can diagnose it often just by clinical appearance or by reported symptoms that a patient is feeling. So for cutaneous and superficial, clinical appearance is enough, right? If your child has diaper rash, you're going to be given an antifungal cream because that's going to clear it up, right? Your pediatrician will know right offhand exactly what that is. The same with thrush, and even the same with vaginal yeast infection. Those clinical appearance, the clinical signs are so specific and consistent that we don't really even need to take a sample to do any sort of further diagnosis. Should we need to specifically diagnose Candida and not something else, you can do a stain and examine directly an aspirate. So if you have a lung infection or something, or a biopsy. And again, we can look for that yeast-like cell with the hyphae. Culture is not always helpful for the diagnosis of Candida. And remember, it's because it's a big part of our normal microbiota. So if you're taking a swab from an area, it could be contaminated with Candida just because it's on your patient, or it could be that Candida is the causative agent. So culture is not always helpful. What we can look for if we're taking an aspirate or a biopsy is that germ tube growth. So this can be particularly helpful in like pulmonary candidiasis, or from a biopsy of one of the more rare ones like hepatic Candida. And so we'll look for that hyphae emerging from the ovoid yeast cells, the germ tube growth. So anyone who's ever had a cutaneous fungal infection knows that they can be, depending on what you have, pretty easy to treat. For those really superficial ones, you can give a topical antifungal, so a fungal cream. That's what we give for babies. It's usually like, I can't remember the name of it now. My kids are too old. I don't need it anymore. Nystatin, that's what it is, nystatin. And it's just a cream that you put on the affected skin area. Kills it off pretty well. And then to prevent, keep areas dry. So in young kids, make sure that they're dry, that you're changing their diaper frequently. In like a nursing home where you may have elderly patients who are not really motile anymore, making sure that their skin stays dry so they don't get fungal infections in their skin. For subcutaneous or systemic candidiasis, fluconazole is the preferred treatment. So when you hear a drug that ends in azole, that's an antifungal drug. So this can be given orally or topically. So you can take oral pills for it. For a vaginal yeast infection, it's often a cream that you insert into the vaginal canal to help kill off any yeast that's in there. So that's more of like a topical kind of application. Some of these may resolve spontaneously when the normal host's body conditions revert. So if it's been like a change in pH that's caused the opportunistic infection, when the pH is back to normal, those conditions may revert on their own without treatment. Obviously, depending on what the patient has, waiting that out may not really be a good choice, so you may treat anyway. Or if it's, if it's like a small patch of skin, you may say just wait and it'll clear up on its own. Oftentimes with these subcutaneous and systemic ones, the best form of prevention is controlling the underlying disease that has made this person become a good host for an opportunistic infection. So if a patient, and we see a lot of candida infections in patients with uncontrolled diabetes, so making sure that your diabetic patients are properly controlling their diabetes, and that'll help prevent not just fungal infections, but other opportunistic infections as well. We can often see candida growing on catheters. So again, and this, we've talked about this before too, removal of catheters, regular removal and replacement of catheters to prevent opportunistic infections there as well, right? Otherwise, it's part of the normal microbiota. Another way to prevent those would be not prescribing antibiotics when they're not warranted. So we had talked about previously about not prescribing antibiotics for UTIs unless they're really severe. Well, that could then also prevent vaginal yeast infection from occurring by not prescribing those antibiotics in the first place. So things to keep in mind as you progress throughout your career and learn more and start treating patients, particularly if you're a GP. And I just want to remind you, before we move on, I'm not going to cover this one in depth, but we did talk about Mycoses eurovetsi. This was the one that's kind of weird. It's like, is it a yeast? Is it a protozoan? It's kind of somewhere in between. It too can be part of the normal microbiota for a few people, not for everyone, and can cause PCP, pneumocystis pneumonia. I'm bringing this one back up because it's another of those AIDS-defining illnesses. And to kind of show you a little bit of difference between how this one looks as compared to aspergillosis. So remember with PCP, we get extensive colonization of the lungs. So these are this is an x-ray of a lung from someone who has diffuse PCP. And you can see that it is found throughout both lungs, pretty much covering the entire lung area. And if left untreated, particularly in AIDS patients, it can result in death because there's just so much buildup in the lungs that people can't efficiently breathe. And it could progress to other areas of the body as well. And then this is what it looks like in a little stain, kind of like yeast, right? It's roundish, but it has that crushed ping pong ball appearance to it as well, okay? So we've learned about a few fungi and protozoans this semester. Most of what we have focused on has been bacteria and viruses, because they're more of what you really are going to be seeing out there. Okay, guys, that's it. A very kind of short one for our last one. You made it. You made it through the crazy semester, half in class, half out of class. So take a deep breath. I didn't have a mid-lecture break because this one was already pretty short. So if you've made it all the way to the end, why don't you email me and tell me what your favorite pathogen that we learned about this semester was. And I'll email you back and tell you what my favorite pathogen was, okay? Last lecture, guys. There's no more. Go forth from here, study for finals, set up meetings with all your professors, and good luck.